just introduced in the ophthalmic practice like the last 10 years. And still, a lot of our colleagues don't know how to interpret the results of the corneal biomechanics. And I think Moataz can explain it to us and tell us how to differentiate if there's a patient with glaucoma or ocular hypertension or low tension glaucoma. I think this is a message that we are looking for to take home after this presentation. Go ahead, Moataz.
Thank you, Professor Muhammad, for your kind introduction. First, I would like to thank Professor Mervat Shabrawi and the organizing committee for arrangement of such an our annual meeting that held for the first time virtually due to the unpleasant situations all the world passed in, and wishing you all to pass the pandemic in a complete health and happiness. My talk today will be about corneal biomechanics, specifically corneal hysteresis and corneal resistant factor with target IOP estimation in patients with glaucoma. No financial interest for any of the presented materials. We all know that the principal goal of glaucoma management is to lower the intraocular pressure to its target level, either medically or surgically. The target intraocular pressure can be defined as the IOP level at which the sum of the health-related quality of life from preserved vision and the health-related quality of life from not having treatment side effects has maximized. In practice, the target IOP is defined as the highest IOP that have no optic neuropathy or optic disease damage, optic nerve damage. Setting target IOP is a multifactorial process that depends on several factors like stage or pre-treatment IOP, age and life expectancy, rate of progression, other diseases, side effects, and patient's compliance. But now, also corneal biomechanical properties have an important impact on the intraocular pressure. It's not a matter of central corneal thickness, but it's a matter of all corneal biomechanics. Here, I would like to present the normal biomechanics or the normal output of ocular biomechanics. We will find that the IOP is within normal levels. Here, the corneal hysteresis is more than corneal resistant factor. The average normal value is about 7 to 8. No specific cut point for the ocular biomechanics in different situations, but in general, the values above 7 or above 8 is considered normal. And so we should consider that the corneal hysteresis is always higher than the corneal resistant factor in a patient with normal intraocular pressure. Here on the other side, in a patient with glaucoma, we'll find that the IOP exceeds 40. We'll find the corneal hysteresis is very low and below the value of the corneal resistant factor. And this is what glaucoma did in the ocular biomechanics. As there is no cut point to determine the target intraocular pressure, our study aimed to introduce a new method for estimation of the target IOP in naive eye with early primary open glaucoma using the corneal hysteresis and the corneal resistant factor. We ran a prospective quasi-experimental study comparing patients with early primary open-angle glaucoma, either perimetric or pre-perimetric, with normal healthy individuals. Patients older than 40 years that are newly diagnosed and not receiving medication yet were included in our study, while patients with other types of glaucoma or on regular treatment or having previous ocular surgery or aphakia were excluded from our study. The target intraocular pressure was determined for each eye of each patient according to the European Glaucoma Society guidelines, either by a monotherapy or a dual therapy. We use here a monotherapy of travoprost and a dual therapy of combined travoprost and timolol. At a baseline, all patients had a full history taking and comprehensive ophthalmic examination. Visual field sensitivity was tested using Humphrey field analyzer. Ocular response analyzer was used to determine the Goldman intraocular pressure and the cornea corrected intraocular pressure and corneal hysteresis and corneal resistant factor. OCT, spectral domain OCT was used to document a baseline peripapillary nerve fiber layer and optic nerve analysis. The statistical analysis of our data involved comparison of a glaucoma patients with controls at a baseline and after 4 weeks of receiving treatment and reaching the target IOP levels, then comparing glaucoma patients with before and after treatment. Our mean target IOP for our patients, according to the European Glaucoma Society guidelines, was 15.50. And here, after treatment, we reached our target. This table showed a significant reduction in corneal hysteresis after treatment. This table shows a significant elevation of the corneal hysteresis after treatment and significant reduction of corneal resistant factor after receiving medications. Also, we can note that before treatment at baseline, the corneal hysteresis was below the value of the corneal resistant factor, while after receiving medication, the corneal hysteresis rise up and became higher than the corneal resistant factor. We can conclude from this table that IOP lower the cornea hysteresis and rise the corneal resistant factor. When comparing our patients to controls, we found a significant difference in all ocular response analyses regarding intraocular pressure before treatment and corneal biomechanics. Here, you can see the value of corneal hysteresis before and after treatment. It's raised, and here the value of corneal resistant factor. We found that glaucoma lowers the corneal biomechanics than normal population. These scatters describe the correlation between ocular response between corneal hysteresis and resistant factor with intraocular pressure. We will find that the corneal hysteresis all over the time, either at baseline, after treatment, or even in our control patients, negatively correlated with intraocular changes in intraocular pressure, either Goldman or cornea corrected. Then corneal hysteresis is always negatively correlated with changes in IOP. On the other hand, the corneal resistant factor is positively correlated. also all over the time, at baseline, after treatment, and among controls. The challenging finding is the relation itself between corneal hysteresis itself and the corneal resistant factor. Before treatment, when intraocular pressure is high, there is a negative correlation between corneal hysteresis and corneal resistant factor. When corneal hysteresis is low, corneal resistant factor is high. This correlation is reversed after treatment and become positive. And this is the same finding among our controls. Then treatment return the normal relation between the corneal hysteresis and corneal resistant factor. Here printouts of some patients. We will find here at elevated intraocular pressure, the corneal hysteresis is generally lower than corneal resistant factor, while after treatment, the corneal hysteresis rise up to become higher than the corneal resistant factor. Another patient, very low corneal hysteresis before treatment, become higher than corneal resistant factor after glaucoma control. However, our study had some limitations that only patients with primary open glaucoma were enrolled. We recommend further studies to evaluate the role of corneal biomechanics in controlling other types of glaucoma using other types of medications. Also, as patients were observed only for 4 weeks, which is a very short duration of follow-up, longitudinal studies were recommended to assess the stability of corneal biomechanics with intraocular pressure control. To conclude, we can depend in practice on the directly proportional correlation between corneal hysteresis and corneal resistant factor in determining the target intraocular pressure level at which corneal hysteresis becomes higher than corneal resistant factor. The ocular response analyzer is a simple, fast procedure, easily interpreted, depends on corneal biomechanics, and can guide us in the assessment of the effectiveness of the medications. Finally, if you want to remember one thing out of my talk, just make corneal hysteresis higher than corneal resistant factor and you will reach the target intraocular pressure and all will be happy. Thank you.